Yeah, just don't. Good morning, everyone. My name is Mike Valley, and I have the pleasure to serve as director of the Mass General Brigham Neurology Residency Program. Welcome to our annual Residency Certificate Showcase today. In addition to our rigorous core curriculum in clinical neurology, our program offers 5 paths for supplemental study in major areas of academic interest to our residents. These innovative programs allow residents to easily connect with experienced mentors across the MGB network and in the greater Boston neurology community to benefit from vast resources available at our institutions and build on skills beyond clinical care that are essential to their future careers. Our 5 certificate programs are Basic Science, Translational and Clinical Investigation, Medical Education, Patient Safety, Quality Care and Health Policy, Global and Humanitarian Health, and Diversity, Equity, and Inclusion. Yesterday, several of our residents presented as part of Brigham and Women's Neurology's Department Grand Rounds, and today we will continue our showcase featuring 3 talks focused on our medical education, global and humanitarian health, and basic science, translational and clinical investigation certificate programs. I would first like to welcome Dr. Minali Nigam. Dr. Nigam hails from Duke University, where she was awarded the prestigious full tuition merit-based Robertson Scholarship and completed a bachelor's degree in psychology. She then attended the University of North Carolina School of Medicine, where she became the first student to simultaneously complete a medical degree and master's degree in medical journalism. She has written stories and worked as a reporter for both North Carolina Health News and CNN. Minali joined the residency in 2021, and over the past 3 years, she has been instrumental in enhancing resident education by designing a cross-institutional headache curriculum as part of her work in our medical education certificate, a subject she will speak more on today. Please welcome Dr. Nigam.
All right. Thank you so much, Mike. I'll be talking about the headache curriculum today, something I've been really passionate about and helped spearhead this year. This was a large collaborative effort. We'll be going through some preliminary data, but then I'll talk about what some future directions we're looking forward to as well with this. So we had 2 main objectives when we designed the curriculum. So the first objective was to create a structured way of having our residents gain headache knowledge. And then the second was to improve our residents' procedural skills. So teach them a formal way of learning how to do occipital nerve blocks so that way they can be credentialed and independently use them in clinical care. So the curriculum origin story started back when I was an NM1. There were a few clinical observations I had that got me thinking about how we can integrate occipital nerve blocks for all of our residents. So the first one was recognizing that there were long clinical referral times to see headache specialists. So I actually had a patient in my resident clinic as an NM1 who had occipital neuralgia at MGH, but the wait time to see a headache specialist for a nerve block was 3 months. And she was suffering in pain and her depression was worsening as a result of this. So ultimately, I was actually able to get her to see a PGY4 neurology resident who ended up shadowing at the Faulkner at the Brigham and learning how to do occipital nerve blocks on his own. And I was like, if you could do that, why can't I do that? And why can't we all do that? So that's really what got me the wheels turning. And then I started noticing on the ED, some of our headache patients there, could occipital nerve blocks potentially reduce their length of stay? And then also thinking about on the inpatient side, on our consult teams, if a primary team is asking us for headache recommendations and we recommend a nerve block, then they would have to consult another team, pain medicine, to actually perform that nerve block. If all of our residents learned how to do this, we could not only recommend it, we could also perform it. We know that peripheral nerve blocks are an effective evidence-based treatment for certain headache types. The most robust evidence for cluster headache, though we also use them for occipital neuralgia and status migrainosus as well. Unfortunately, formal nerve block training is not an ACGME requirement, which really limits its use during residency training. So we completed an informal needs assessment prior to even creating the headache curriculum proposal. So I worked on this curriculum extensively with Dr. Gaiman, and she was in communication with Dr. David Chen here, who was offering a half-day clinic elective for residents to come shadow him. He has some protected time where he just does procedures for his patients. So we sent out a sign-out sheet back in December of 2022, and we had over 20 MGB residents sign up to join the wait list. By the time we proposed the curriculum, 10 of our residents had a session with Dr. Chen and gave us feedback that they thought this was a valuable learning experience, and they thought that this was an unmet need in our program, and they wanted to have more formal training to be able to independently perform them. So this is a large overview of what our headache curriculum looks like this academic year, and I'll break down each individual parts, but just to talk about the overall structure that we had. Starting in June of 2022, we had our incoming neurology residents, PGY2s, fill out a pre-survey assessing their confidence and competency in occipital nerve blocks. And we had them participate in a headache simulation case. They have a simulation case as part of their orientation week. And so headache is one of the 6 cases that we launched this year. In July, we sent the PGY2s an email detailing what the sign-off process is to get credentials for nerve blocks. We gave them some pre-reading and a video demonstration. And then we also had one of our headache faculty members give a lecture during the boot camp didactics. In August, we held a hands-on fundoscopic and nerve block workshop, which I'll talk about in more detail. And in the fall, we started offering the advanced week-long headache elective for our senior residents, our PGY3 and PGY4s. And then starting in the beginning of this academic year, so July of 24, every PGY2 was assigned a half-day clinic block at the Faulkner. Because of some schedule trades, there were 3 or 4 PGY2s who ended up having that scheduled in the first half of the year. But for the most part, all of them were in the second half. We continue to offer the advanced headache elective for our seniors. And then looking ahead, we're hoping next year for our new PGY2s to also have protected time at the Faulkner. And then for our now future PGY3s to have a half clinic day at MGH with Dr. Chang. But I'll talk all about the details shortly. So this was the pre-survey results that we sent the PGY2s during orientation week. We had them self-rate on a Likert scale what their confidence was in understanding and performing occipital nerve block. So we had them rate their confidence on a scale of 1 to 5, 5 being most confident. As you can see, the red indicates no confidence. And majority of incoming neurology residents don't know the clinical indications or risks and benefits of occipital nerve blocks, and 86% of them had no confidence in performing the procedure, which is not unexpected. And we had them also fill out 5 multiple choice questions assessing their knowledge in the use of occipital nerve blocks. They scored on average 30%, again, not completely surprising. So overall low confidence and understanding the indications for occipital nerve blocks. And then we designed a new headache simulation case that was included as part of the Stratus session. The Stratus session usually has 6 different neurologic cases. The headache one was introduced this year, and we designed it based off of intracranial idiopathic intracranial hypertension. The goal of this case was to teach our residents how to distinguish red flag signs and symptoms so they could recognize primary versus secondary headache. So 21 residents participated in this. They were organized in groups of 3 to 4, and there was an attending headache facilitator and then a standardized patient. This year that was me. We had 5 different phases of the simulation. So the first part was history taking that all the residents participated in. The second part was doing a focused physical exam. We posted images of papilledema on the PowerPoint, so they got some hints. And then we reviewed brain imaging. So we showed, we had arrows pointing towards empty cell sign, global flattening, tertuitous optic nerves, things to try to recognize for elevated intracranial pressure. And then all of the groups got the IH diagnosis, which was pretty remarkable, considering they didn't have any neurology training at that point. But then they got the diagnosis, they educated the patient, and then the last phase was a debriefing session where we taught them the Snoop mnemonic and talked about the case. And again, the key for this simulation case was just getting a basic understanding of red flags, signs, and symptoms. At the end of the Stratus session, the Stratus facilitator sent out a satisfaction survey, just asking the residents to rank on a scale of 1 to 5, 5 being most satisfied, how they thought of each individual case. The headache case was the highest ranked among all 6 cases. The average satisfaction score was 4.7. We were really excited about that as a launching point since it was the first year that we had done the case. Moving on to our August hands-on nerve block and fundoscopic workshop that we offered. So we designed this to happen simultaneously at Brigham and MGH during a Moon conference. So we had 2 different stations. So one station was the fundoscopic station. Residents learned how to assemble a panoptic, what are the ophthalmologic landmarks, and at the Brigham side, we had Shashank, who taught that session, and at the MGH side, we had Annalie, one of our neuro-opto fellows, teach that station. And then we had a mannequin and a nerve block demonstration. So we basically taught anatomical landmarks on the mannequin and taught the proper technique of how to inject the local anesthesia for the nerve block. And so with this, we also had headache attendings at both sites run the station. And so residents rotated through both stations. And then at the end, we asked them to fill out a feedback survey for us. We wanted to assess what their confidence was in certain skills before the workshop and then after the workshop to see if this was something that was beneficial and if we should offer it again. So the different things we asked about were if they knew how to assemble a panoptic, how confident were they in understanding ophthalmologic landmarks, anatomic landmarks for nerve blocks, and knowing the proper technique. So as you can see in the red and orange, people either had no confidence or low confidence for most aspects of this. And then after the workshop, people were at least neutral, if not extremely confident in all of these skills. Looking through the individual data, every single person had a delta increase in their confidence level, except for one resident who was extremely confident in their ophthalmologic skills going in. But everyone else did benefit from this workshop, and it was a unanimous. When we asked you to offer this workshop again, it was unanimous that yes across the board in the survey. All right, so now talking a little bit about the advanced headache elective that we created for the seniors, the PGY3s, PGY4s who were interested in opting in to learning how to do nerve blocks. This specific elective was really focused on procedural skills. So initially, the first half of the year, we offered it as a 4-day elective. So half the time at the Faulkner, half the time at MGA's with Drs. Lin Chang or Dr. David Chen. We got feedback throughout the year to try to shorten it and offer it more frequently so it could accommodate people's schedules, which we did. So we now streamlined it so that it's only 3-day elective, 1 day at the Faulkner, and 2 half days at MGH. With the goal of being able to perform enough nerve blocks so that they could be credentialed by the end of the 3-day elective. So we actually sent out the same pre-survey a week before the residents scheduled advanced elective time. It's the same pre-survey that we sent to the PGY2s back in June, assessing the competency and confidence related to nerve blocks. And then at the end of that week elective, we sent out a post-survey to see if it made any improvement or changes in their knowledge and confidence. So the sign-off process, and this is standard for both PGY2s and the seniors who were part of the advanced headache elective. So we designed a standardized nerve block checklist. This was based off of some anesthesia 2014 guidelines that were created for peripheral nerve blocks. We modified it slightly so that we included certain specific headache indications related to occipital nerve blocks specifically. This sign-off process, there is not a huge rigorous scientific methodology behind it. We just modeled it off of how some programs have the residents signed off on lumbar punctures. And we don't actually have a specific way of signing off our residents for lumbar punctures. So we modeled this after a few other residency programs. But What we designed is we wanted residents to first observe 2 nerve blocks and then complete 5 supervised nerve blocks with the supervisors using this checklist. And then once they had those 5 supervised nerve blocks, we asked them to log these nerve blocks through New Innovations. And then once they logged the procedures, then they were sent a post-survey. And after completion of the post-survey, they could be formally signed off. So at this time, we currently have 7 residents who are independently signed off to perform nerve blocks. All right, so thinking about future directions and where we go from here. I mean, the goal is really to have all of our neurology residents, one, just get good headache education and knowledge, but then also to be able to independently perform occipital nerve blocks for their patients. We haven't completed the post-survey analysis yet since we only have data from about like 5 or 6 residents. But we're hoping by the end of the next academic year, all of our PGY3 residents would have had enough nerve block exposure that they can then complete the post-survey. So we're hoping to see if the headache curriculum did anything to improve the confidence and competency. Keeping in mind that a big confounding factor, especially for the competency part, is that residents may just gain the knowledge through going through neurology residency as opposed to the headache curriculum in and of itself. Thinking about further analyses, how do we create an educational project and create outcome measures that actually affect patients and quality improvement? So once we have enough residents, I'm hoping that we could do some chart review and look to see if ED length of stay has decreased. Is there increase in headache medicine fellowship? Does referral time decrease now? If we have residents who can do occipital nerve blocks, can we reduce referral times to headache specialists and have patients see residents instead for certain aspects of headache care? And then our hope is to create a model and make our curriculum generalizable so that more neurology programs can include this within their curriculum. There are 2 programs in New York who are actually who have reached out and want to adapt parts of our curriculum for their residents. So that has been an exciting collaboration as well. So what can we conclude so far? So incoming neurology residents have limited knowledge and indications for nerve blocks, and they have low confidence in performing them, but they're interested in learning how to do them. Our curriculum was introduced as a way to try to address some of those gaps. We designed the headache stimulation case and hands-on fundoscopic nerve block workshop, and this was very favorable among our residents. I'm working with Rashad to actually figure out a date for it next year as well. And then, you know, this specific workshop increased confidence in being able to perform the skills both for the fundoscopic exam and nerve block technique. Thank you to all these individuals listed here. I won't go individually, but this was a large undertaking that required a lot of coordination. Our chiefs were instrumental in getting the schedules together so that every resident could have, every PGY2 could have the Faulkner experience. So thank you, everybody.
We have a minute or 2 for questions. So, Dr. Sindel.
That you go. Question is as the curator to implement the processes in the ED, including the headache pipeline. We propose the cost.
Yes, so the question was, I'm thinking about some of our ED protocols, and if we can include occipital nerve block training for ED residents as well, or just in general? Yeah, that's the hope. I mean, I'm hoping that if we can try to include occipital nerve blocks as prior to protocol, that would be great. Yeah. Yeah. Amazing. Thank you. Thanks, everybody.
Our next speaker is Dr. Franziska Hoche. She is a chief resident in our child neurology residency program here at MGH. She received her MD from Goethe University in Frankfurt, Germany, where she completed a pediatric residency and a doctoral thesis on cerebellar pathology and spinocerebellar ataxia and Huntington's disease. Dr. Hoche joined Dr. Jeremy Schmahmann in the Laboratory of Cerebellar Anatomy and Neurobiology here at MGH for her postdoctoral work on cognition and movement in pediatric cerebellar disorders. She is the recipient of the Young Scientist Award, the Clinical Fellowship Award of the German Neuropediatric Society, and most recently received the Enhanced Residency Leadership Award at the American Academy of Neurology just this year in 2024. Besides her work on the pediatric cerebellum, Dr. Hoche is passionate about advancing pediatric brain health in underrepresented populations through global neurology research and advocacy. For today's grants rounds, she will present her work on autism education and advocacy in Uganda, East Africa, as part of the Global and Humanitarian Health Certificate Program. Please welcome Dr. Hoche.
Thank you so much, Mike, for the introduction, and thank you for the opportunity to present this work today. So I'm going to talk to you about autism education research and advocacy in Uganda. And as with many projects, this project more or less fell in my lap and started in pediatric residency clinic when I met the mother of one of our residency clinic patients, Pamela Titi, who came for follow-up to receive care of her daughter who suffered a neonatal stroke. And as we were talking, she told me about how she struggled finding care for her daughter in Uganda, which is due to lack of access to medical care resources, lack of trained occupational therapists, speech language therapists, and physical therapists. So this is where we met, and this is where the story starts. So it's in fact a mother's story. So just to give you some background about Uganda, Uganda is a landlocked country here. It's situated right between Kenya, Sudan, the Democratic Republic of Congo, Rwanda, and Tanzania. It has a large population of estimated roughly, probably more by now, 47 million, which is doubling every 16 years. And more than 50% of the country's population is under age 16 years, 15 years. Uganda is resource rich. It is a tourism hotspot. It has access to water sources and a lot of natural resources. And it's plays an important role in promoting security in the region, acting as a partner with the US government, as a mediator in conflicts in surrounding countries. However, Uganda has also significant challenges with their healthcare system, which is mostly related to an extreme shortage of healthcare workers, lack of government funding, and poor quality of healthcare services in general, as well as lack of trust in them. There's an approximate estimated 5 child neurologists in entire Uganda. However, 4 out of 5 work in private settings, which is inaccessible to the majority of the population. There's no formal child neurology training. This year, we traveled to Mbarara Referral Center Hospital, which is an academic center in Western Uganda, which has more or less the only accessible neurology and child neurology clinic outside of private practice. And this referral center is run by 2 pediatricians with some neurology training, and those pediatricians are assisted by pediatric residents. So you can see us meeting Dr. Kalubi here. And this is the pediatric ICU at Mbarara Referral Hospital. The hospital has access to 1 CT, 1 EEG, but there's no MRI, nerve conduction study, or any other screening available. Now, children with neurodevelopmental disabilities, and especially children with autism, are amongst the most neglected population in Eastern Africa and Uganda. 13% of Ugandan children live with a disability, and that approximates roughly 2.5 million children in total. Unfortunately, recent legislative changes related to Ugandan anti-LGBTQ legislation have further challenged the inclusion of people perceived as different from societal norms. And in general, children with disabilities are at extremely high risk to be subjected to physical, sexual, or emotional abuse, or may be neglected by their caregivers. Further, autism spectrum disorder research in low and middle income countries has been largely disproportionately represented. So while the WHO recognizes autism spectrum disorder as a growing global public health concern, and that it may represent some of the greatest burden of disease in children and adolescents, with 90% of the world's children and adolescents living in low and middle income countries, only 10% of autism spectrum research is performed in those countries, which is also known as the 90-10 divide. So we set out 4 project parts or 4 goals for our collaboration. Project part 1 included education of the center staff. So Pamela, my collaborator, funded a center about 10 years ago, one of the first centers in Uganda, where she trained occupational therapists, speech language therapists, and physical therapists to work with children with all ranges of neurodevelopmental disabilities, including autism. The second project part included autism and disability advocacy. So we were both meeting with families, caregivers. We educated the public with reliable information on autism spectrum disorder and neurodevelopmental disabilities by means of TV interviews and broadcast interviews. We wrote local university articles and met with families to promote diversity and inclusion. The third part, which is what I will show you data, I will show you more data upon, is included the development of an autism education conference and education research. So more or less the first autism education conference in the country. So we launched this in 2022 with the first conference taking place in 2023. And the second follow-up conference in a rural region this year. Project part 4 included promoting support, visibility, and inclusion. For example, we did organize a paid workshop for families, parents, and conference participants, as well as local artists. So now I want to show you more about the data on the research project. So we wanted to evaluate the impact of an educational intervention on knowledge, perception, cultural beliefs, and associated social stigma of autism spectrum disorder in Uganda. And we were also interested in whether the educational intervention may have the potential to change misperceptions, improve stigma related to autism spectrum disorder. So we developed a 2-day conference workshop targeting teachers, parents, and community leaders. The workshop covered topics related to the characteristics of autism spectrum disorder, the diagnosis and management. We then administered a cross-sectional pre- and post-conference survey, collecting qualitative and quantitative data regarding knowledge, cultural beliefs, and perception. And then we performed a single cross-sectional post-conference survey, evaluating the educational satisfaction regarding this intervention. And the instrument was adapted from published educational assessments, and we adjusted the instrument cross-culturally. So just to give you a basic overview of the conference topics, so we included both definitions of autism spectrum disorder, the etiology, how to diagnose autism spectrum disorder, current evidence-based management strategies, but also transition into adulthood. So this was an important topic of this conference, probably one of the most requested topics by the conference participants, because this is completely unknown. There is no such transition into adulthood of individuals on the autism spectrum. We had 94 registered participants that attended the educational conference. But throughout the two-day course, we estimate that there were 120 participants. 28 of those participants completed both parts of the pre and post intervention survey. So some respondent demographics. So our population that attended the conference was quite young, so with the majority being in their 20s and 40s, slightly more female than male respondents, and a good mix of healthcare professionals, teachers, educators, but also a lot of families and patients. And it's important to note that the population that we studied was quite highly educated. And that is the case because our conference took place in Kampala, which is one of the largest cities in Uganda. However, if this conference moves to the rural regions, this profile will change. Some results of the pre versus post-intervention survey. So some common misconceptions that we wanted to inquire about. All autistic people have intellectual disability, and we all know that it's not, there is a large spectrum of intellectual skills, with some being on the high intellectual capabilities and some patients who may have, in fact, a degree of intellectual challenge. And the blue bars show you the pre-intervention knowledge, and the orange bars show you the post-intervention knowledge. And for all those domains, the answer spectrum shifts from incorrect to correct in the majority of answers. For example, on this one here, what are some common signs of autism? Difficulty making eye contact, delayed speech and language development, repetitive behaviors and routines, or which clinical signs must be present to make a diagnosis of autism spectrum disorder, which includes behavior patterns such as obsessive or repetitive interests or routines and difficulties in social interaction, engaging in conversation, or reading social cues. And then I just want to give you one example of a parental interview, which I think is always underlining what actually happens within those families. So this is Jill. Jill was the mother to a 11-year-old boy who did have a diagnosis of a neurodevelopmental disorder. On review in the office with the exam that we performed, he didn't meet diagnostic criteria for autism spectrum disorder. So this is what she told us. I knew something was not right when he was 6 months old. He did not make eye contact while nursing. Doctors told us to send him to school so that his behavior could be corrected with strictness. There was no speech, language, or occupational therapist familiar with his condition, and he was restrained, in fact, chained to the wall when he had a tantrum and was beaten. He did not learn to speak until we started therapies at the therapy center. My family told me to hide my child from the public eye as they believed he was cursed. I was shamed for conceiving a child who was not able to cook or clean and was viewed as a financial burden. So this is what the families live with on a day-to-day basis. So after the intervention, we wanted to know, has perception changed? And just to give you one example here, has this conference encouraged you to assume the role of a community teacher, thereby educating others about autism? The answer to this question was only answered by 11 participants, but all of them answered yes. And do you think broader autism education can help mitigate stigma, leading to better mental and physical health outcomes for individuals with autism and their families? And the answer was also yes. So in summary, the post-intervention survey revealed an increase in knowledge about autism spectrum disorder and identified factors contributing to stigma, such as limited access to knowledge, misconceptions, lack of awareness, unfamiliarity with the condition, limited access to resources, especially medical and therapeutic resources, associated financial strain, often the risk for abuse and neglect, which further enhances stigmatization and marginalizations. However, it also showed that participants felt empowered to become local community educators to decrease stigma on a rural community level. So in conclusion, an interventional an educational intervention program can improve knowledge about autism spectrum disorder and the perception of educators, parents, and community leaders. And it encourages and empowers community leaders to become patient advocates. And as Pamela and I said, kind of summarizing the work that we do, advocacy begins by shining a light on seemingly small topics, starting with just one disease, one condition at a time, illuminating pathways to equality, and just a single flame can ignite a spark that progresses across inequality, paving the way towards a more just and inclusive society. And with that, I want to thank you and all the people involved in this project, Pamela, my collaborator, most importantly, her staff, her family, all the families at the Tunawesa Center, Drs. Anne Newmeyer and Shelley Wade, who assisted with the development of the conference curriculum, Dr. Thomas Berg, who advised on the general approach to this project, and Mike and Chris as certificate program directors. Thank you.
Questions for Dr. Hoche?
It's a very daunting task. For most of the kids in Uganda, the kids care for a couple of institutions.
Most of the kids are cared for at home. That is correct. Yes.
They have access to the beds.
There's very limited access to any intervention management therapies. So the centers that offer occupational therapy, physical therapy, speech language therapy are extremely limited. Many of them are financially straining to the families, and the public hospitals do not provide similar services that would be needed for those children. So most kids are being taken care of in their families. And some of them are sent to school, but there is also a significant lack of knowledge on how to interact with children, autistic children and autistic adolescents, which leads to the fact that they are more or less separated during the school day.
Say statistics, like in many countries.
Very true. Yeah, correct. I did not understand that. Yes, so there are efforts actually that Pamela just presented this work at the International Child Neurology Conference in South Africa. I think we can approach Africa through regions. For example, East Africa, Southern Africa, West Africa, etc. And there are efforts to streamline the educational interventions. There is also more work needed with regard to understanding what is the prevalence of neurodevelopmental disorders, especially in in Africa in general, but particular for Uganda. We don't have the exact numbers, but we know the numbers are probably much higher than we anticipate. So there is a lot more work to be done. Screening tools are not available, etc. Yeah.
Our last speaker this morning is Dr. Amine Awad. Dr. Awad attended college at McGill University in Montreal, where he majored in neuroscience before attending medical school at the University of Oxford in the United Kingdom. During his time in residency, he has developed a clinical and research interest in acute stroke systems of care and clinical outcomes research. After residency, he will be pursuing fellowship training in vascular neurology at Stanford before returning for a neuroendovascular surgery fellowship here at Massachusetts General Hospital. Please welcome Dr. Awad.
So thank you very much for having me and for the opportunity to present some of the work I was involved in during my time here in residency. So again, this was, as is the case for many of us, inspired by patient encounters early in my time as a neurology resident down in the emergency department, where we were making decisions around acute stroke interventions for patients presenting within windows of eligibility, both for TPA and for mechanical thrombectomy. And one thing that stood out to me early on as a important consideration in determining eligibility for these interventions was a patient's baseline level of functioning, as we commonly define using a modified Rankin scale. And there was a certain perception of futility with regards to the efficacy of these interventions in patients with severe baseline disability. So I wanted to take a look at the data here locally a little bit more systematically and kind of do a bit of a deeper dive around the history of that and what the data shows regarding outcomes in this patient group. But so just in terms of a little bit of background, we know that on average, around a third of all patients with acute ischemic strokes will develop a form of permanent post-stroke disability. And it is the leading cause of disability worldwide still. However, one thing that is perhaps less well known is that the direction really is, the relationship really is bidirectional. And we know that patients with baseline disability are at higher risk of developing new acute ischemic strokes. And on average, if we take all comers of patients with acute ischemic strokes, around a third of those patients have a pre-existing disability. So they represent a significant percentage of patients with acute ischemic strokes. Fortunately, over the last 30 years or so, initially with intravenous thrombolytic therapy, and more recently in the past 10 years with mechanical thrombectomy, we now have very effective interventions to try to minimize the neurologic deficits accrued from acute ischemic strokes. However, those pivotal trials, including both for intravenous thrombolysis and for mechanical thrombectomy, have historically excluded patients who had baseline disability from their inclusion criteria. So that's led to some concerns or some controversies around the safety and efficacy of these interventions in this patient group. However, over the past several decades, several folks have looked at sort of observational data. Overall, the gist is that these interventions seem to be fairly safe in patients who have premorbid disability. However, there is a bit of a dearth of data directly comparing outcomes in patients with baseline disability, comparing best medical management and mechanical thrombectomy. So we had a couple of goals. We wanted to look at patients, particularly on the higher end of the spectrum. And for folks who aren't familiar, so the modified Rankin scale is a 6-point scale going from 0 to 5, and then 6 being death, with higher numbers representing higher levels of disability. And it's a functional scale with some weight or more weight towards mobility as a measure of disability. And that has its own criticisms and own limitations, but is the most prevalent measure of disability that we use in stroke clinical trials and outcomes research. So our main goals were, in our institution, what are the outcome differences long-term in terms of disability between in patients with severe baseline disability who undergo endovascular thrombectomy versus best medical management. But another angle that we thought would be worth pursuing and looking at is, what does end-of-life care look like for patients, for these patients? And in particular, we're often dealing with patients who are on the whole older, who have significant medical comorbidities, and a major ischemic stroke may represent a significant and possibly terminal event. And so we often find ourselves at the juncture of end-of-life care when these patients present to our emergency departments or wherever with a large new ischemic stroke. So we were also curious to see, how does our decision to pursue such quote-unquote aggressive treatment influence our decision around end-of-life care for patients who do not do very well following these procedures? So in order to look at this, we looked at our institution here, looking continuously between January 2017 and December 2020 at all comers directly through the emergency department and as transfers from our spoke hospitals who had a CTA-defined large vessel occlusion stroke and had a baseline MRS score of 3 to 5. So as would be defined as moderate to severe baseline disability. And we were interested in kind of examining outcomes in these two separate cohorts, those who underwent mechanical thrombectomy and those who were managed with best medical treatment alone. And then our primary outcome of interest was what we defined as the 90-day delta MRS, meaning their change in the level of disability at 90 days out from the stroke, defined as their 90-day MRS minus their pre-stroke baseline MRS. But as I mentioned already, we were also interested in examining the comfort care transition. So for those patients who did not do well and were made comfort measures only and subsequently passed, what were the overall rates between those two groups? Was there any difference in the median time it took to reach that decision? What were some of the cited reasons qualitatively for those transitions? And so in terms of what we had around 175 patients who met those criteria, and really a minority of patients underwent mechanical thrombectomy, around 18% of eligible patients, and the far majority underwent best medical management. When we're comparing the baseline demographics between those two groups, couple of main pointers on the whole, these were older patients with kind of the mean age around 81, 82 in both groups. But otherwise, in terms of traditional baseline risk factors for stroke, they were fairly well spread out between both groups. There was one significant difference in terms of their acute stroke presentation, with their NIH stroke scale being slightly higher in the group that underwent mechanical thrombectomy, but that was a minor difference between the two groups. And so in terms of the primary outcome we were interested in was the disability outcome. So on the whole, taking all comers, including patients who were made comfort measures only, we did note that there was a improved overall 90-day delta MRS in the patient group who underwent mechanical thrombectomy. This is kind of corroborated with what other groups have found in their kind of observational data on the whole. So even when controlling for things like age and their NIH stroke scale, which was significantly different between the groups, there seemed to be some treatment effect from EBT. But we also were curious to see, what does that data look like for patients who were not transitioned to comfort care, so when we didn't pass away that hospitalization. So in other words, stroke survivors, how did those fare in comparison with medical therapy versus EBT? And for that, we did what are called sort of Grata bars, commonly used in stroke outcomes reporting. And on the top is sort of medical management, on the bottom is kind of endovascular therapy. And we were curious in sort of the change in the MRS that happened at 90 days. So overall, on the far left, so a delta MRS of 0 means no accrual of any disability compared to baseline. MRS of 1, it means an increase on the scale of 1 point, and then 2 and 3. Given that we recruited, or we only looked at patients with at least a baseline MRS of 3, then a delta MRS of 3 means patients passed away. But on the whole, what we found here was that there was a greater percentage on the whole of patients who retained their pre-stroke disability at 90 days. Or had a minor increase in their baseline disability, and a reduction in the percentage of patients who had a significant increase in their baseline disability. So overall, if we consider a positive outcome being maintenance of someone's pre-stroke level of functioning and quality of life, then we seem to have a kind of good proxy measure for that kind of being an achievable outcome here. And now kind of going on to our second point of interest there, which was comfort care transitions. So we're a little surprised to find that overall, the percentage of patients who were made end of life kind of comfort care within that hospitalization was the same in both groups. So there was no impact there on treatment. However, what was significantly different was the median time it took to make that transition to comfort care. So for patients who have severe baseline disability presenting with a large vessel occlusion stroke. We're talking like a big MCA stroke, for example. Most were made comfort measures within 48 hours of their admission. And in fact, around 38% were made CMO within 24 hours of their presentation. So there is this perception on the whole that a large vessel occlusion stroke is seen as a terminal event in this patient group. And we do know from the ICH literature that there is some risk of a self-fulfilling prophecy with early withdrawal of care in patients with devastating vascular neurologic injuries. What was different, however, and so in the EVT group, the median time was 7 days. There's a significant difference in how long it took for that decision to be made. Some of this could very well be rooted in biases that that once we do an intervention of this sort, we want to give it a little bit more time to be sure that it has or hasn't worked and kind of have a better sense for what the patient's long-term outcome is. But one unintended effect of this is that it also gives us perhaps a little bit more certainty around what the patient's long-term prognosis is going to be, and therefore kind of better grounding perhaps to make life or death, literally, decisions for these patients. The counter side to that, however, is the utilization of fairly resource-intensive care, primarily in the ICU during this period of time. So looking at, we examined the charts of all the patients who were transitioned to comfort care and looked at all the advanced care planning notes to try to get a sense for what the physicians were thinking were the primary reasons to shift that goals of care. And on the whole, what was interesting is sort of biases that were very evident and kind of the way that these conversations were framed. And overall, patients who were managed medically alone, there was a perception that their prognosis was fairly poor as a result of the stroke. Whereas patients who underwent mechanical thrombectomy, the perception was a little bit more on the side of, well, that they're less so likely to do poorly because as a result of the stroke and more as a result of some of the medical complications that are inevitable, such as aspiration pneumonias and related complications. So on the whole, some strengths and limitations, and this is sort of a single center study and it's retrospective. It is primarily Caucasian in our patient population around that time, between 2017 and 2020. And although we did try to control for as many variables as we could, there is always a risk, obviously, of selection bias in deciding who goes for a mechanical thrombectomy and who doesn't. On the positive side, we did have continuous inclusion of all patients in our database, and we were able to compare directly sort of outcomes of very similar patient groups within the same kind of geographical setting. So some take-home points from that. So first of all, we know that patients with severe baseline disability represent a significant percentage of patients with acute ischemic strokes that have historically been excluded from the pivotal trials. So in our cohort, EVT was associated with less post-stroke accumulated disability at 90 days, but did not delay transitions to comfort care in appropriate patients. It did, however, increase the length of time it took to make that decision, for better or for worse. And we do, so therefore, I believe that an EVT is compatible with goal concordant care and shouldn't be routinely withheld on the basis of severe baseline existing disability. And that's it. I want to thank my research mentor, Dr. Regenhart, and the whole group for their help on this process.
So this is fantastic. I very proud of you when we have this. We know that these patients fall out of the guidelines and too restrictive with thrombectomy, so we need options. This is really great. A question in terms of the selection. So it was on about two things. So what was driving the disability? What was the cause of this underlying disability? And why are these patients selected? It was different about them than you guys decided to do.
Yeah, so regarding the first point, I think we did include both cognitive and physical disability. And our data was similar to the trends overall that, you know, that patient group, the 33% with new ischemic stroke, around a third have a cognitive disability. So dementia, for example, was one of the more common, and again, represented in around 30 to 35%. The rest were related to primarily kind of cardiovascular disease, and sort of very sort of orthopedic type of kind of ailments where patients had reduced mobility, were no longer kind of independently mobile, and therefore scored highly on the MRS. And we had around 10 to 20% who had cancer related sort of disability, either directly from the cancer or from the treatment. And so, and regarding the second point, and that's, I think, the key thing that's really hard to pin down, one of the main limitations of this observational data, which we try to control for all these things we can in terms of variables that we capture. You know, what makes that decision ultimately between, you know, going for mechanical thrombectomy or not. From what I could tell, just, you know, deeply diving into kind of our patients' chart seemed to be, when that data was available, it seemed to have been kind of a strong family kind of wish following family discussions. But none of the other kind of medical variables were different between those two groups. So that was the main thing. And again, it just maybe speaks to the fact that, you know, we don't have very clear guidelines or clear you know, indications to intervene or not in this patient group. And so that decision can sometimes fall on, you know, just purely family and knowing what the possibilities are. But yeah, so I think that, you know, that hopefully once we do have sort of more randomized data, we can control for those and make decisions in a more systematic way.
I mean, did you look at the change in maintenance score versus the decision?
Sorry, say that one more time.
The change in maintenance score versus the decision.
Yeah, I mean, the ideal, we were interested in kind of long-term for MRS. There are 2 points where I think we commonly capture the MRS score is a discharge and on 90 days. And all those patients who were transitioned to comfort care were done so within that hospitalization. So it wasn't kind of formally measured or captured, but those are, I mean, patients who fortunately had minimal neurologic recovery. So I think their MRS would have been around 5 or so at the point that the decision was made.
So that changing modified maintenance scale to approach it.
So we did include them in the kind of overall analysis, and in those patients, there was, even including those, there would have been MRSs of 6 in the analysis, and they were included, and there was still overall a trend towards improvement, even if you consider those patients who passed away during that hospitalization.
Well, thank you, everyone. And thank you again to each of our speakers. Enjoy the rest of your day. Thanks, folks.